As a doctor with over 20 years of experience, there's one phrase I've seen do more damage to people over 60 than half the diseases I treat. It's just a routine test, just to be safe. Today, I want to share something I usually only say to other doctors, in those quiet hallway conversations with a cup of coffee in hand, where people finally stop being polite and start being honest. These are the 5 intestinal tests that, after 60, I myself would think twice before agreeing to, and I'm going to walk you through exactly why, not with a wall of medical jargon, but with the plain logic of someone who has seen both sides of this. Why am I telling you this? Because I've watched the same pattern play out again and again. I've seen a simple, just-in-case test, done on someone with 0 symptoms, spiral into a cascade of fear, anxiety, and invasive procedures that never needed to happen. I've sat with healthy, vibrant people in their 60s, 70s, 80s who walked into a clinic for a routine checkup and walked out feeling like fragile patients, labeled, almost broken, all because we went looking for a problem that wasn't announcing itself and very likely never would have. This has a name in medicine. We call it the cascade effect. It starts small, one test that looks harmless enough, but that one decision sends out a ripple. Maybe the result comes back as a false positive, or an incidental finding, some tiny anomaly that means nothing, like one more wrinkle on the skin. But modern medical protocol, sometimes obsessed with leaving no stone unturned, demands a second test, and that second test, more invasive than the first, carries its own risks. Meanwhile, the person who felt perfectly healthy is now living with the anxiety of a possible problem. Their peace of mind is gone, all from a decision that seemed responsible at the time. In this video, I'm not just going to tell you what these 5 tests are. I'm going to walk you through the actual clinical reasoning behind each one. We'll look at why the balance between risk and benefit shifts, sometimes dangerously, as we age. And most importantly, I'll give you the exact questions you should be asking your doctor so you can take back control of your own health. And let me be clear about something. This is not about avoiding your doctor. Quite the opposite. This is about demanding smarter medicine. Medicine that understands that after 60, quality of life isn't a bonus. It's the whole point. So if you're ready to hear what doesn't always get said about gut health screenings, stick with me. Let's get into it. The first test on my list is, without question, the most famous one out there, the gold standard for catching colon cancer, a test that has saved countless lives and is recommended almost universally starting around age 45 or 50. I'm talking about the colonoscopy, and I want to be very clear here. The colonoscopy is an extraordinary tool, in the right person at the right time. It doesn't just diagnose, it treats. It lets a doctor see inside the colon and remove polyps before they ever become something serious. So why does it make my list of tests I'd seriously question doing routinely after 60 and would likely decline altogether past 75 without symptoms? The answer isn't the test itself, it's how the scale between risk and benefit tips as we get older. A decision that's completely logical at 50 can become a real gamble at 80. First, there's the prep. Anyone who's been through it knows it's brutal. That bowel cleanse with liters of laxatives isn't just unpleasant. In an older adult, it can be genuinely dangerous. Dehydration is a real risk. Electrolyte loss can trigger irregular heartbeats or episodes of confusion. I've had older patients fall in the middle of the night rushing to the bathroom and end up with a broken hip. We set out to prevent a future problem and end up dealing with an emergency in the present. But the real hidden danger is in the procedure itself. Picture your colon like a garden hose. At 30, it's flexible, resilient. At 80, it's more like an old hose that's been sitting in the sun for years, stiffer, thinner, more fragile. Now picture threading a scope through it and inflating it with air just to get a clear view. In a younger colon, that's usually safe. In an aging one, the risk of perforation, low as it is, somewhere between 1 and 3 in 1,000, becomes a genuinely serious possibility. And a perforated colon isn't a minor complication. It's a major surgical emergency that can mean an operation, a colostomy, and a recovery that, for many older patients, steals their independence. Then there's the sedation. Older bodies process medication more slowly. That raises the risk of a sudden drop in blood pressure, post-procedure confusion, even more serious events like heart attacks or strokes. And finally, the part that matters most, the actual benefit. The whole point of a colonoscopy is to prevent death from colon cancer. But the journey from a small polyp to invasive cancer usually takes years, often more than a decade. That's exactly why the guidelines recommend screening only up to age 75. Past that, between 76 and 85, it becomes an individual decision. Why? Because if someone at 82 has a life expectancy under 10 years due to other health conditions, removing a polyp that would take 15 years to turn dangerous offers almost no real benefit. We'd be taking on immediate risk to prevent a hypothetical problem that will probably never show up. I still think about Walter, 81 years old, a retired carpenter with a heart condition that was well controlled. His doctor pushed for a routine colonoscopy. The prep left him completely wiped out. During the procedure, they removed a small, harmless polyp. But in recovery, his blood pressure crashed so badly he spent 3 days in intensive care. He left the hospital weak, and it took him nearly 2 months to get back to his workshop. The result of all that? A polyp that was never going to hurt him. Walter took on an enormous risk for a finding that meant nothing. So what's the smarter alternative? This isn't about skipping prevention. It's about doing it more safely. Tests like the fecal immunochemical test, which checks for hidden blood in the stool, are an excellent option. You do it at home, no prep required, no risk involved. If it comes back negative, great. If it comes back positive, then a colonoscopy makes real sense, because now there's a solid reason to take on that risk. Smart prevention isn't about doing more tests. It's about doing the right test at the right time. We've covered 2 tests in depth, and I hope this is genuinely useful to you. We're questioning some deeply held assumptions here, and my goal is simple, to give you the judgment and clarity to make your own decisions. If this kind of thoughtful, honest medicine is resonating with you, I'd really appreciate it if you hit like and consider subscribing. It tells YouTube this content deserves to reach more people, and it lets me keep making videos like this one. It takes 2 seconds, it costs nothing, and it genuinely means a lot to me. Thank you. Now, let's get into test number 3. Test number 3 sounds like it's straight out of science fiction, but it has a dark side too. It's the capsule endoscopy. You swallow a tiny pill that's actually a miniature camera, and it travels through your entire digestive tract, snapping thousands of pictures. Sounds incredible, right? And it is, in the right context. It's a fantastic tool for examining the small intestine. But, and this is a big but, using it as a screening test or for vague symptoms in an older adult is something that genuinely worries me. The reason is a risk that doesn't get talked about enough, and it can turn into an absolute nightmare, the capsule getting stuck. Think about it for a second. The capsule has no motor. It moves through your body purely by the natural muscle contractions of your intestine. In a younger person, it usually sails through without a hitch. But in an older adult, digestion tends to move more slowly. On top of that, there's a higher chance of narrow spots, strictures that have gone completely unnoticed. These narrowings can come from old inflammation, diverticula, previous surgeries, or even long-term use of anti-inflammatory medication. So what happens if that capsule reaches one of those narrow spots and simply can't get through? It gets stuck. The overall rate is low, around 1 to 2%, but in older patients, that risk climbs noticeably. And when it happens, the capsule stops being a diagnostic tool and becomes a foreign object that can cause a full intestinal blockage. Getting a stuck capsule out isn't simple. Sometimes it requires a complex procedure called an endoscopy. And if that doesn't work, or if the blockage is severe, the only option left is surgery. Yes, abdominal surgery to remove a camera the size of a vitamin pill. For someone in their 80s, that can be devastating. I remember a patient, Dorothy, 78 years old. She had mild anemia. After a few basic tests came back inconclusive, her doctor ordered a capsule endoscopy to get a better look. 3 days later, Dorothy showed up in the emergency room with severe abdominal pain. The capsule had gotten stuck. It turned out she had a stricture that had never caused a single symptom before. She ended up in surgery. The operation went fine, but recovery was long, slow, and exhausting. And the actual cause of her anemia? A simple iron deficiency, something a supplement would have fixed. On top of all that, just like the virtual colonoscopy, the capsule endoscopy is purely diagnostic. If it spots something concerning, it can't take a biopsy, it can't treat anything. In most cases, that means signing up for yet another procedure. For me, the capsule is a specialist's tool reserved for very specific situations, like an active bleed with no known source. I would never consider it a first-line test for an older adult. Test number 4 is basically a fossil in the world of radiology. Honestly, it surprises me that it's still used anywhere. I'm talking about the barium enema. The procedure is exactly as unpleasant as it sounds. A thick, chalky liquid, barium, is introduced into the colon through the rectum. The patient has to hold it in while x-rays are taken from multiple angles. Trust me, it's a miserable experience for everyone involved. Today, this test is considered outdated and, frankly, risky in older adults. For starters, there's a risk of colon perforation, somewhere between 2 and 5 in 1,000. And when it happens with barium in the mix, the consequences can be especially severe. Another major risk is barium impaction. Barium is essentially liquid chalk. If it isn't fully cleared from the body, it can harden into a solid blockage, causing a full bowel obstruction. I've seen patients suffer for weeks because of exactly that complication. On top of all that, there's radiation exposure, and the image quality is far worse than what you get with a colonoscopy. It can easily miss small polyps or flat lesions. It's like trying to diagnose a modern car's engine problem using nothing but a stethoscope. If a doctor suggests a barium enema for you after 60, my advice is simple. Get a second opinion and ask directly what the modern, safer alternatives are and why they aren't being considered first. We've reached test number 5, and this one is especially sneaky because at first glance it looks like a perfectly reasonable alternative to a full colonoscopy. It's the flexible sigmoidoscopy. Essentially a mini colonoscopy, it uses a shorter scope to examine only the final section of the colon. It's faster and in many cases doesn't require deep sedation. For years, it's been marketed as the less invasive screening option. And yes, it's true the risks are lower than a full colonoscopy. But here's my real objection to it. It hands people a false and dangerous sense of security. It's a half measure dressed up as a full solution. Imagine hiring an inspector to check out a house, but he only looks at the basement, then tells you, all clear, the house is safe. Would that actually put your mind at ease, or would you start wondering what's going on up in the attic? That's exactly what a sigmoidoscopy does. It examines only the final stretch of the colon. But recent research shows that in older populations, more and more polyps and cancers are showing up on the right side of the colon, a section the sigmoidoscope simply never reaches. That means you can get a sigmoidoscopy, receive a report that says everything's normal, and walk away thinking you're in the clear, while a serious lesion quietly grows in a part of your colon that was never even looked at. It's an all clear that only covers part of the map. A colleague once told me about a 68-year-old patient who got regular sigmoidoscopies for years, every single one coming back normal. Over time, he started developing anemia and losing weight. Eventually, a full colonoscopy revealed advanced cancer in the ascending colon, the part farthest from where the sigmoidoscope had ever reached. For years, that sigmoidoscopy had been giving him false reassurance, a full decade of false negatives. If he'd simply done an annual fecal immunochemical test instead, there's a real chance the problem would have been caught years earlier. In today's world, where we have highly effective non-invasive tests like the FIT test available, the sigmoidoscopy as a primary screening tool has largely lost its purpose. Why settle for a partial exam that's uncomfortable when you can do a test at home that evaluates the entire colon? It's like peeking through the keyhole when what you actually need is to open the door. So, what have we learned today? We've walked through 5 intestinal tests that, after 60, deserve a real, well-informed conversation with your doctor. The routine colonoscopy is an excellent tool, but its risks, the prep, the possibility of perforation, the sedation, mean it's worth seriously questioning whether it's still necessary past 75, especially with no symptoms present. The virtual colonoscopy might look like an appealing alternative, but it comes with real radiation exposure and often triggers a chain of follow-up tests thanks to false positives, frequently ending right back at a traditional colonoscopy anyway. The capsule endoscopy is a fascinating piece of technology, but it carries a real risk of getting stuck, turning a simple test into a genuine medical emergency. The barium enema is a relic, uncomfortable, imprecise, and carrying risks that simply aren't justified anymore. And the flexible sigmoidoscopy is that dangerous half solution, one that can hand you a false sense of security while leaving unexamined exactly the part of the colon where the real problem might be hiding. The takeaway here isn't to be afraid of medicine. It's the opposite. It's an invitation to practice medicine that's more thoughtful, more personalized, to have the courage to question what's routine, to have the courage to ask why, to have the courage to say, I want to understand the risks and the benefits before I agree to anything. In my own view, smart prevention isn't about doing more tests. It's about doing the right ones. It's about understanding that, especially past 60, quality of life isn't a side consideration, it's the entire goal. So what should you actually do? Talk to your doctor. Don't just accept its routine as an answer. Ask, what are my actual risk factors? What less invasive alternatives exist? What happens if we choose to monitor instead of acting immediately? Lean on non-invasive tests when they make sense. For colon cancer, stool-based tests like the FIT test are an excellent starting point, safe, effective, and easy to do. And don't forget the most important part. Real prevention doesn't live only in test results. It lives in your daily life, in what you eat, how much you move, how you manage stress. Fiber, hydration, exercise, and emotional balance make a real, measurable difference. Listen to your body. Don't ignore persistent symptoms, changes in your bowel habits, bleeding, unexplained pain. When symptoms show up, the entire calculation around testing changes. I'd love to hear your experience in the comments. Have you ever felt pressured into a test you weren't sure you needed? Your story might help someone else make a more informed decision. I'm Dr. Leonard Brooks, and I'll see you in the next video.